morning half, afternoon another half also can.
All right, doctor.
Okay, because otherwise we cannot finish the lecture. We have too many things lag behind. So can we start already? Everyone log in already?
Yes, doctor. I think we can start already. Most of us are here.
Okay. Okay, can you guys see the screen?
Yes, doctor.
Yeah, so I think last 2 weeks we were talking about endocrine system. So finally this week we are moving on to another system already. We're moving out into kidney and urinary tract disease. Okay, this is another important topics, one of the core topics that you guys need to understand because this is very relevant in the exam as well. And the range of disease and disorders affecting kidneys and urinary tract disease is huge as well, and a large number of disease we will go through. Hopefully, you guys can understand the pathophysiology and hopefully know about the treatment as well of each disease. So, anyone from Sabah Sarawak here?
Me.
Yeah, Mark, you're from
Me.
Sabah, right?
Me.
Yes,
Yeah, so
a
do you
lot
know
of
what is
us.
this? Do you know what fruits or that's in the picture here? Anyone know what is this or not? It's a type of sort of like a jungle fruits in quite famous in Sarawak. Anyone acknowledge or recognize what is this? Oh no, all are city guy, all are town people, is it?
Yeah.
Okay. Maybe this thing is more common in Kuching. Anyone from Kuching? Okay, maybe no one from Kuching. It's called jering. It's a type of like ulam like that. It's a jungle fruit that's quite common to find, uh, not just in rural area. Actually, a lot of people actually eating this in their daily meals. But the problem is this jering actually can cause a very bad nephropathy that causing bad kidney injury requiring dialysis. Okay. Later we'll talk more about that. All right. So in the first part of the lecture, we'll talk a little bit about normal anatomy. How does the normal kidney function? How does the urine form? And then we'll talk about how do kidney problem usually present with. How do we investigate any kidney problem arise? And then we will go through common problems or common diseases affecting the kidney and the urinary tract systems. Okay. So this is a normal anatomy of our kidney. If we slice the kidney in half, you see this kidney into uh, two different anatomy here. So anatomy, kidney actually divided into two layers. The outer section here is called a cortex, and then the inner section is called the medulla, something like a fan. This is called medulla. Outer one is your cortex, and on top of kidney you have your adrenal gland. That's what we learned last week's lecture. And then supplying the kidney, you have your vein and your artery. Artery is labeled in red, and your vein is labeled as blue. So blood will enter through the renal artery and go through the filtration system, and then the clean blood will excreted via your uh, renal vein. It's something like a co-way. Your co-way also have two wires, two water tubings, one red and one's blue. It's almost a very similar concept. Okay. All right. So when your blood enter through the renal artery here, maybe here is clearer. Okay, when your blood enter through your renal artery, the renal artery will actually further subdivided into smaller vessels called arterioles. And then following the renal artery and renal arterioles, eventually you reach an area called Bowman capsules. Okay, before you go into the vein. So you follow through the renal arteriole and then you will go into here. You go into like globules like that. And this area, the vessel is actually semi-permeable and you force through a high pressure and and then continuing out, draining to the kidney. So when the blood vessels are being forced through at the high pressure, all the electrolytes will get forced through into these Bowman capsules. So imagine all your bloods are filtering through a filter membrane, and filtered content will go into the Bowman capsule. All your electrolytes, all your waters will get filtered into your Bowman capsule. Well, larger molecule like your proteins, your red blood cells, because they are larger, they cannot exit through the endometrial membrane. They'll stay on into your vessels and then go back to the renal. They'll connect back to the renal vein. Okay, so what happened is that the filtering actually all happen in this tiny function. All these are single units called nephrons. We have millions of these functional units. And what happened here, filtration will take place here, reabsorption happen here, and secretion also happen in these nephron units. Okay. So like I mentioned just now, in each of these nephron unit, the capillaries will intervene with these tubules, and the tubules will carry away the waste and the water. So during the filtration here, the body fluid is forced through into the tubules here. Okay, so the large molecules stay in, but the smaller molecule like your electrolytes, like water, all get forced through into this Bowman's capsule. And eventually this Bowman capsule will connect and drain into the loop of Henle, and then you go to collecting duct, and this collecting duct eventually will drain into the bladder, becoming urine. So not all filtered substances or filters contain they are useless. That's why reabsorption happen in the tubules to prevent loss of electrolytes and loss of water. While our body only want to filter the toxin, that's unwanted products. Those wanted electrolyte, wanted water will get reabsorbed in between here. The capillary network will reabsorb the water and electrolyte, preventing loss of electrolytes. Okay. So you do not need to remember or familiarize in the whole thing. You just need to know that filtration happen at the nephron. All the unwanted waste product will get filtered through. Wanted electrolytes and water will get reabsorbed back to your systemic systems. So what are the functions of the kidney? Kidney function is to regulate, remove the waste products, regulate your electrolyte balances, regulate your acid balance, and also control your blood pressure by regulating the water content and also regulating your sodium content. The kidney plays some endocrine function as well. Most important you need you to remember is the EPO production, erythropoietin secretion from the kidney. These are important. This hormone is important for red blood cell production. That's why chronic kidney patients that develop anemia, partly because of EPO deficiency as well. And then another endocrine function of the kidney is the important role in the RAS system, the renin-angiotensin system. It helps to convert angiotensinogen to angiotensin 1 and also angiotensin 1 to angiotensin 2. All these are important for the vascular contractility and also blood pressure control. And it also play a role in the vitamin D metabolism. Okay, so this one, no. Okay, so in examination of chronic kidney patient, there are a few things that you can notice. There are a few positive signs, but most of the time it's not very specific. On general inspection on the kidney-related patients, they're usually very tired because of uremia. There may be tachypneic as well, and an increase in the depth of their breathing because of metabolic acidosis. We call it metabolic breathing, acidotic breathing. Patient will be more tachypnic, they appear tired, and they have a sallow looking on their face. You check their nail, they may have a brown line pigmentation of the nail. Spindle hemorrhage, not really. Their skin is always yellowish and reduced skin turgor due to fluid depletion. They will always have that. Most of the time they will have high blood pressure because of the chronic kidney disease. HLB may be raised due to fluid overload status. And their eyes, if you look at the fundus of the eyes, you will see hypertensive changes. And chronic kidney disease patient, most of the time they present with fluid overload symptoms. So in examination, you hear crepitation in the lung. Right? And sometimes you may expect to hear renal bruise in the renal stenosis patient. They may also have ankle edema, left neuropathy on the lower limbs, and you check urinary cysts, there will be proteinuria. And most of the kidney disease and urinary tract disease, they are clinically silent. They do not have much symptoms. Then they may even present very late with the symptoms of uremia and overload. So most of the time, they only detect by your checking on the biochemical testing and renal profile. Okay. So what are the symptoms that you can pick up in the disease of the kidney? Basically, we can divide them into a lower and upper urinary tract symptoms. Lower urinary tract symptoms usually are the common UTI symptoms that we hear. Patient will present with dysuria, frequency or urgency. Those are lower urinary tract infection symptoms. They may have pain, passing urine, they have increase in urine frequency, and also they have urgency, the sense of inadequate voiding, and keep on wanting to go to the toilet. Okay. Some patients with upper urinary tract symptoms, most of the time they will have loin pain and tenderness. Your renal punch will be positive. Okay. Then you may have kidney disease patient, they will have reduced urine volume as well. And in acute renal failure, the patient will have reduced or no urine output at all. And in nephropathy patient, they will have polyuria because they cannot concentrate the urine. Okay. Other than that, that most of the time there will be no symptoms in chronic kidney disease patient. Okay, so we skip these slides first. We have another slide talking about the causes of kidney injury. Okay. So what investigation can you do on the kidney disease patient? So the most common thing you can do, first non-invasive and commonly available will be your urine dipsticks. So there are different urine dipsticks available in the market, but generally in the hospital, you have a complete urine dipstick that's checking for your the bile, urobilinogen. You can check urine glucose, urine ketone, the specific gravity, the blood, urine pH, protein, nitrates, and leukocyte. So most of the time, the one that we are interested in will be your pH, blood, protein, nitrate, and leukocyte. Okay, so what does it tell you? So increase in the leukocyte and nitrite always point you towards urinary tract infection. So when there's increase in leukocyte and it means that there's increase in concentration of your white blood cells inside the urine. This may indicate infection in the kidney and also your urinary tracts. Okay, well, nitrite actually testing for gram-negative bacteria that can convert nitrate to nitrite. So it's positive. It's actually quite specific for urinary tract infection, but not in all cases they will turn positive. Okay. Another component important will be your urine protein. Urine protein, they are indicating of microbe or albuminuria. All these are indicate of kidney disease, especially early kidney disease. Okay. And blood usually is a non-specific. It can be positive in the urinary tract infection, can be positive in stone-related disease as well. Okay. Glucose will turn positive when the patient has uncontrolled diabetes. Okay, any question until this part?
No, doctor.
Okay, doctor.
Okay. Okay, then we will talk a little bit in details about how do we evaluate hematuria and proteinuria. Okay, we'll try to simplify the evaluation for you so that it won't be so complicated. So how do we evaluate hematuria? So if we look at the basic anatomy just now, we have our kidney. We have two kidneys, left and right. Your cortex or medulla, and the kidney eventually will drain into your ureter. Ureter will be two draining tubes that drain the urine into the bladder. So the ureter, you insert the bladder, 2 points here, and that depends on male or female. Eventually, you will drain into a urethra, and you pass out urine from here. In male, you have another prostate in between the bladder and also urethra. So for hematuria, basically anything's happened from the kidney to urethra, any stones, any growth or inflammation can give you hematuria. That's how you evaluate hematuria in male and female. So the common things that can cause hematuria will be renal stones and also infection. Those are things you need to remember. Okay, other causes usually are less common, but there are more specific ways to evaluate this. So you follow this flow chart, evaluating hematuria, you want to know whether there's any proteinuria and any dysmorphic FBC or not. So why do we follow this? So if there is a hematuria or blood formed, maybe we skip this. This is a bit too complicated for you. Okay, so hematuria, just remember common thing. There's two causes when you see blood inside your urine. The common thing will be infection, urinary tract infection, or pyelonephritis, pyelonephrosis. All this can cause bleeding or blood inside your urine. Number two will be your renal stones. Then in the kidney, there are also other causes like renal infarct. Those are not common as well. Happen in hypoperfusion or septic emboli. Tuberculosis is also not common. The common thing is still stone. So stone give you hematuria. At the same time, it also give you pain, especially when you have stone obstructing the ureter. So when you stone at the ureter, you have obstruction here. You have backflow of urine. You have obstruction in the systems. So this gives you pain, and your renal punch will be positive. Okay, remember this one. So when you have stone inside your bladder, especially at the base of the neck of the bladder, you have hematuria as well. Typically, the pain will be after the end of the voiding. So imagine, because your bladder is full, your urine can pass out, but when your urine already or finishing out, your bladder is in your stone is in contact at the bladder neck. So usually at the bladder stone, patient will complain of pain and hematuria at the end of the voiding process. Okay, and prostatitis, prostate cancer also can give you hematuria because of the inflammation. Okay? Other less common causes of hematuria including glomerulonephritis, inflammation of your glomerulus. So inflammation of the lining of the glomerulus and nephritis, all this can give you hematuria. And another one will be your bladder cancer. Bladder cancer give you painless hematuria. All right. Anyone not clear about hematuria? Okay, let me try to repeat another time. Okay, hope that you guys can get this. Okay, basically we divide your hematuria into painful and painless. So more common thing is still painless hematuria. So common thing is still renal stone. Always remember stone and infection first. Infection can happen in the bladder, we call UTI or cystitis. Infection can happen at the higher up, upper urinary tract, which is your kidney. Okay, we call it pyelonephritis. Can give you hematuria and give you pain. Another one common causes of hematuria will be stone-related disease, renal stones. The stone can happen in the bladder, happen in urethra, can happen in the kidney itself. Okay, number 2 is the stone. That's for painful cause. Painless cause of hematuria, you can remember it by different location. Like if it is in the kidney, it can be malignancy in the kidney, renal cell carcinoma. In the bladder, it will be bladder tumor, and in the prostate, it can be prostatitis or prostate cancer. Okay, so you guys can remember this part. Any question on hematuria?
No, doctor.
Everyone get that? Huh? Okay. Then number 2, next thing, evaluation of proteinuria. Okay, so basically proteinuria, we divide. I forgot about these slides. This is a bit complicated. Remember this one. So this one. Okay, so basically we classify our. How do we evaluate our proteinuria? We always quantify them. We want to know whether this is nephrotic or non-nephrotic range of proteinuria. So nephrotic range means your 24 hours urine protein more than 3.5 gram per day. Okay, remember this cutoff number. Later we'll come back to nephrotic range of proteinuria again. So there are different causes of nephrotic syndrome. We will divide into primary and secondary. I think we will talk more in the subsequent slides. So common causes of nephrotic syndrome in our population is still diabetes mellitus, and primary cause disease including minimal change disease, FSGS, and membranous glomerulopathy. So we have another segment to talk about nephrotic syndrome in a while. Okay, so this is how we divide our proteinuria. Normal people, you do the dipstick will be negative. So you can further classify into micro and macro. Macro means is very overt. Micro means is you won't able to see. You can only detect it by checking your urine, 24 urine protein, or you doing a USCR. So our job in daily practice is try to pick up microalbuminuria in our daily appointment or screening for diabetic patient, so that we can pick up those early proteinuria patient and try to prevent them from progress into overt or macroalbuminuria. Okay. So besides urine dipstick, what other renal function that we do? That's what we call renal profile. Renal profile, there's 2 components in it. One is your urea, another one will be your creatinine. So both are measured in our renal profile. But urea itself is not a good guide because it varies with your protein intake. Can also affect by your liver metabolism capacity and also your renal perfusion. That's why we never take urea as a representative of your renal function. So the other component that's more reliable that we are seeing every day is creatinine. That's why when we check renal function, the first thing we ask is how is the creatinine. But creatinine itself is not to say 100% accurate because it's produced by muscles, and there's other factors can increase and decrease the serum creatinine. We'll look at the subsequent slides. Okay, so the creatinine is produced by the muscles, and it actually filtered at your glomerulus. So there's the increase in creatinine actually represent by the reduced filtration of your glomerulus. So any changes in creatinine concentration reflect the changes in your GFR. However, if you look at the relationship between your serum creatinine and your GFR, Okay, any increase outside of normal range only actually not seen until your GFR reduced by 50%. So that means your early changes of GFR, you will not change in it. You will not see any changes in creatinine. Only at very late stage when your GFR is reduced more than 50%, only the creatinine start to raise. So it's not a very good marker for early or mild changes of kidney injury as well. Okay. So urea is not good. We do not take this to represent our renal function because there's too many variable can affect the number of urea. Creatinine is something more reliable, but it actually can affected by your muscle loss. So if patient has a muscle injury, your creatinine will be raised, and creatinine actually affected by your muscle bulk. So if you look at it, patients that do muscle buildings, those are bigger in size, their creatinine always higher. While elderly patients, those are very thin, cachexic, sarcopenia, muscle bulk is very small, creatinine is always very low. So when they have their creatinine always like 60 to 80 because their muscle bulk is less, doesn't mean that their renal function is perfectly normal. So the thing more reliable will be your filtration rate. So how do we count the filtration rate? So there are certain three different in our daily ward work. We're following the Cockcroft-Gault equation. So you do not need to remember the formula. Just remember that creatinine itself is not fully reliable. We are measuring the filtration rate by formulas. So this filtration rate is more presentable and more reliable to measure the kidney function. So in this formula, it take into consideration the patient age group, male and also female. It's sort of to standardize to make our renal excretion function more reliable when taking into account of the creatinine. So we classified the CKD stages using your GFR. So we have 5 classes of kidney disease, 1 to 5. So in stage 5 kidney disease, the GFR will be less than 15. More than 90 is stage, it will be the normal. We call it stage 1, everything is normal, more than 90. Mild reduction, 60 to 89, will be stage 2. Stage 3, we divide into 3A and 3B, 45 to 59, and lower will be 30 to 44, that's stage 3B. And if it worsen further, 15 to 29, that's stage 4. Okay. So you do not need to remember these stages as well. I don't expect you to remember the numbers. Just remember that this is important for us clinician. Mainly is to when we communicate with other doctors or other groups of doctors when we talk about stage 4, stage 5 kidney disease, so that people are on the same line or same picture. But in exam, I will not give you a number to ask what the stage of disease. So just to remember when there are kidney failure, when they are in end-stage renal failure or advanced kidney disease, usually their creatinine is their GFR will be less than 15. So we usually pick up patients when they have mild disease, when they're in stage 2 or stage 3, so that we can do some intervention. So the referral usually done when the patient achieving around stage 2 and stage 3. When they're in advanced disease, usually the referral will be for renal replacement therapy rather than intervention to improve kidney function.
Doctor,
Yeah.
for the renal function, right? Would you ask like a question about like what rate do we use to assess renal function like that?
Usually the question will be very clinical scenario based. Sorry, I'm having flus, that's why my voice a bit, I cannot talk in very fast and full sentence. Okay. So usually my question will be like this. Patient comes in with hematuria, or patient came with a pain, fever, reduced urine output. What will be the investigation that you want to do? And the reason. Usually I will ask something like that. I will not ask in details of numbers. Okay. or I will give you a number. Maybe I give you a number of creatinine 300. Normal is 100. Now it's 300. So what condition the patient is having? You should answer me acute kidney injury, something like that. Understand?
Understand, doctor.
Yeah. Usually you wouldn't play the numbers game lah. I wouldn't ask so much about the definition, like the numbers and classes. Yeah, I won't try to fight for in such details. It's not fair. Okay. All right. So the investigation you need to know. Number one will be your urine dipstick. You need to know the component of urine dipsticks. Number two will be your renal function. Okay. And number two will be just renal ultrasound. Those are the common thing. And the common causes of hematuria, common causes of proteinuria. Okay. No need to remember names that you can't even pronounce. Those are too difficult. I will not ask that. Right? Okay. Then yeah, just need to know what is GFR, and just know there is classification of CKD. Okay, now we talk about the disease that can affect your kidney. So number one will be your urinary tract infection. So we have two groups of UTI, your lower UTI and the upper urinary tract infection. More common is still your lower urinary tract. Lower means what? Lower means anything affecting your bladder and urethra. Upper means anything upper than your bladder. Can be your urethra, it can be your ureter. Ureter is the tubules that connect your kidney and your bladder. Urethral is the one that draining your bladder out to your body. So you guys can see my mouse, right? So the kidney and your kidney, your ureter, this is upper. This is our upper system. This is your lower system. So it's one of the most, UTI is one of the most common bacterial infection that you see in our daily life. In GP, in the common clinic consultation, those are the most common cause of infection. Even in hospital as well, up to 50% of female will have UTI at some time, and the prevalence is actually 3%. It's quite common, I would say. Male, on the other hand, will be more uncommon. So anyone know why or not?
It's the length, the distance.
Correct. One of it is the anatomy itself. Male urethral typically is longer, and female urethral is shorter. And another anatomy difference is the male and female. Because female has vagina, and vagina is just situated just in front of your rectum. So there's a very close distance to the rectum. There's bacteria. So one habit of cleaning after you're passing urine, the wiping practice is one of the important factors as well. If you wipe from front to back, that's the correct way. But imagine if you wipe for female, if you wipe from back to front, you're actually wiping the bacteria from rectum to your vagina. So this introduces bacterial flora into the urinary tract system and increase the chances of infection. Okay. So that's why in female is more common, and in male, most of them they will have this infection in elderly, because that's where your BPH start to set in, your obstruction starts to set in because of prostate hypertrophy. Okay. Most of the time, the kidney, the infection can cause some morbidity, especially in elderly patient. In young patient, not so much. After most of the time, can self-limiting, or after a course of antibiotics, you get better. But in elderly patient, actually can cause more morbidity, because it can cause more extensive systemic infection. Elderly, the UTI can turn into septicemia, can turn into a bad kidney injury, and hypotension or in shock. Okay, so what symptoms patient will have? Because like I mentioned just now, common one will be a fever, dysuria, frequency, urgency. in patient have systemic symptoms, they will have fever, they have chills and rigors. Okay, they have pain and burning sensation when you pass urine, cloudy urine or smelling urine. If it's severe or bad enough, patient will have hematuria, passing red cola colored urine color. When in female, they may have a bad pelvic pain, especially at the center of the pelvis. Okay, so remember the symptoms of UTI. So when the infection start to track up, become upper urinary tract symptoms, patient tend to have loin to groin pain. When you do renal punch, patient will have pain at the back. Will have a positive sign of renal punch. Okay. So what are the risk factor of urinary tract infection? So iatrogenic causes will be indwelling catheters. Patient with uh, long-term indwelling catheters, like those who cannot control their urine, those patients have BPH obstruction or incontinence that requiring long-term indwelling catheters, always give a route for bacterial seeding. Okay, prolonged or frequent use of antibiotics also increase the risk of UTI as well, because you disturb the normal flora. Okay, the next one is your behavioral problem. How you clean yourself, frequent sexual intercourse, all this can introduce bacteria. Okay, physiological or anatomical abnormality. All these vesical urethral reflux are the inborn anatomical abnormality, because this can cause urinary retention. It's not commonly seen. Okay? Female itself has a short urethra, so this gives a higher chance of infection, like Mark said. Okay, pregnancy itself can increase the UTI risk as well, because the hormone can cause a smooth muscle relaxation. So all this causing urinary retention. Okay, and of course other less common genetic causes. Forget about this part. Okay? So the spectrum of disease, patient can be asymptomatic. They can carry the bacteria in the bladder. We call it asymptomatic bacteriuria. Especially in female or elderly, they may carry the bacteria without causing symptoms. So this group of patient, you may not need treatment, and they can progress and turn into symptomatic. Whereby they will have cystitis, have pain on passing urine. When the infection get worsened, it can speed up, become pyelonephritis, and the infection affecting your upper tract, including your kidney. When things get systemic, the bacteria seep into the blood. We call septicemia. Usually, it will be a gram-negative sepsis. Patient will be very septic with chills, rigor, and septic shock. So, commonly in daily practice, we are seeing patient at cystitis, especially in elderly. When this cystitis or UTI is ignored, that can turn into pyelonephritis and eventually turn into septicemia. So in the urinary tract infection, common bacteria will be gram-negative. Gram-negative like E. coli, the common bugs. You do not need to know the names of the bacteria. You just need to know the common infection bacteria is gram-negative bacteria. And one of it, more than half of it is usually E. coli. So in infection lab symptoms, what investigation you want to do? Number one would be non-invasive, commonly available of course, is your urine analysis. So what do you expect to see in your UFAB? Anyone remember this now? So in UTI, what will happen in your UFAB, your dipstick?
Blood.
So there are a few things can be turned positive in UTI. That commonly in particular we are interested in the leukocyte and also nitrite and your blood hematuria. So most commonly, leukocyte and nitrite will turn positive if let's say there is a urinary tract infection. Okay, urine culture is to isolate what bacteria is in the urine. This is for us to guide our antibiotic treatment. Okay, of course you want to do other basic blood tests. Full blood count is to look for your white cell. Any elevated of white cell count, this can tell us how serious the infection is. Renal function, renal profile, the urea and creatinine. We want to look, we want to see any affected or AKI or not, any affected renal function. Does the renal function get affected due to the infection or not? We are looking at the GFR. Okay, CRP is an inflammatory marker which will get elevated in infection. Okay, blood culture. If patient get admitted requiring parenteral antibiotics, we want to know whether there is any systemic involvement or not. We want to know any septicemia or not. That's why we take the blood culture. Other imaging is needed when patient has, when you suspect patient has obstructive symptoms, or if let's say patient has very bad kidney function, creatinine suddenly come in few hundred, then you need an ultrasound KUB to look for renal stone. Okay. Cystoscopy. Anyone know what is cystoscopy? Yeah, like the name suggests, cyst is actually a bladder. Scopy means the camera looking into the cavity. So cystoscopy is actually putting a camera into the bladder. So usually it's a rigid scope. It's a very tiny scope, a few size of rigid scope that is like a straw like that. It's very long, rigid metal bar that insert through your urethra uh, into and directed into your bladder. It's mainly to evaluate hematuria patient, to look for the opening of the orifice of the urethra to see any mass inside or not, especially painless hematuria. You want to look for bladder cancer or to look for bladder stones. So that's what cystoscopy for. Okay, so what do we give in urinary tract infection? So we want to target gram-negative bacteria. Commonly that we use will be cefuroxime, cefalexin. Cephalosporin will be our first-line antibiotics. Alternative, you can use augmentin, amoxicillin with clavulanic acid. Okay. The common is to remember cefuroxime. Just one antibiotic for all types of urinary tract infection. Just remember cefuroxime. Okay. Yeah, the rest, if you look at it, cefuroxime cover everything. So just remember cefuroxime. All right. So with someone with prophylactic with recurrent urinary tract infection, there are other prophylactic measures you can do. Because habit change, good personal hygiene, like I mentioned just now, clean yourself from front to the back rather than back to the front. Drink a large amount of fluid per day. This can dilute out your bacterial load. Regularly emptying your bladder to prevent accumulation of bacteria in the system, and always empty the bladder before and after sexual intercourse. All these can clean out the system. So another things that popular in the European countries, cranberry juice. It's not commonly available in Malaysia. Where do you find cranberry juice in Malaysia, right? So cranberry inside that has antioxidants and also these proanthocyanidins is thought to prevent bacteria from adhering to the tracts, can reduce the formation of biofilms. So this help to prevent recurrent UTI. It's commonly adopted or advice given in overseas patients, but not much in Malaysia because not commonly available. Okay, any question on UTI?
No, doctor.
Okay, then we will move on to talk about kidney injury. Okay, where are we now? Oh, we are just half of it. Okay. Okay. So the next half we'll talk about kidney injury and also end-stage renal disease. Okay. So what is acute kidney injury? Acute means it's reversible, something recent. Then there's injury to the kidney. Means it's something injured a kidney is potential reversible. That's what we call acute kidney injury. Alright. So how do we classify? How do we work out the causes of acute kidney injury? So usually we divide into pre-renal, renal causes, and post-renal causes. One. So in acute renal failure, it means there's a sudden and usually there's a reversible cause of loss of the renal function. It can develop over a period of days or even weeks. And in acute renal failure, usually the urine volume will reduce. Most of the time it's multifactorial, and if you do not correct the causes immediately, you may temporarily you may need renal dialysis. So we have we divide into three groups of causes of renal injury. Pre-renal means before the kidney. Remember, we have blood supply or renal artery to the kidney. All these are the source of the urine volume. So if you have reduced perfusion, you can cause renal injury. Pre-renal causes, whatever causes that reduce your kidney perfusion. Commonly, it will be in shock patient. Patient have cardiac failure, sepsis, low blood pressure due to infection, due to blood loss, or due to dehydration. This can cause renal injury. Like dehydration, usually you have to be a very severe loss of loss of water volume in the body. Like your marathon runner. Marathon runner, if they do not replenish their water consumption, they will have significant dehydration, and on top of that, they will have muscle injury due to prolonged running. All these are the common pre-renal causes. Okay, well, renal causes will be whatever causes affecting the renal itself, like commonly will be drugs, toxins, and also inflammatory causes or infection of the kidneys. Okay, and other will be inflammation of the kidney like glomerulonephritis and small vessel vasculitis. Post-renal causes is something quite common as well. Means post-renal means after the kidney. So when the urine come out to the urethra, is considered post-renal. Anything from the kidney below is post-renal causes. So if you have an obstruction here at the urethra, this will block all the urine volume. You have an obstructing causes. So common post-renal causes will be renal stones, bladder stones, BPH. When you have BPH severe enough blocking the urine outflow, you will have very severe obstructive uropathy. Okay. So this is very important slides. So remember this one. Remember these causes of renal injury: pre-renal, renal, and post-renal. Most of the causes that we see in the clinical scenario is still pre-renal and post-renal, and renal causes is relatively uncommon. Okay, again, this is just a different illustration of the similar information. Pre-renal causes, whatever causes that reduce the renal blood flow, like in shock, bleeding, trauma, or poor cardiac output. Okay. Post-renal causes is whatever causes that causing obstructive neuropathy. Whatever causes that obstructing the urine flow, like renal stone, bladder tumor, BPH, or strictures. And the intrinsic renal causes, medication, and also inflammation like glomerular nephritis. Okay. Again, the similar information, different illustration. So it come out 3 times already now. Just jot this down, it's very important. Okay. So how do we treat different causes of acute kidney injury? If the causes is due to reduced perfusion due to pre-renal, you need to correct the hemodynamic derangement. If patient is dehydrated, you replenish the fluid. If patient is losing blood, losing the volume due to bleeding, you want to replenish the volume by transfuse the patient. Okay? If the problem is post-renal obstruction, patient has obstructive uropathy, you need to relieve the obstruction by stenting the patient by putting a nephrostomy tube or urethral stents. Okay? If patient have BPH, they are blocking the causing obstruction, you need to put in a Foley catheter to divert the obstructions. Okay. Well, intrarenal causes is something more difficult. If due to medication, you identify the medication which is the culprit and you stop the medication. Okay. Okay, so usually establishing the acute renal failure is not so difficult because how do we detect acute renal injury or acute renal failure? We usually measure their we usually measure their GFR by checking the creatinine. So most of the time we will compare with their baseline renal function. Okay. So what will happen in acute renal failure? Usually their urine output or urine volume will be reduced. In sudden acute renal failure, remember the renal function just now, the start of renal function. The kidney also responsible to regulate the water, electrolyte, and acid base balance. So in acute renal failure, patient will have hyperkalemia. Potassium will be sky high. They will have dilutional hyponatremia because they cannot excrete the excess water. And patient will have metabolic acidosis as well. Patient cannot excrete the urea, cannot regulate the urea. So they will have high urea, it's called uremic. Uremic symptoms including nausea, vomiting, and it's severe enough, patient will be drowsy, confusion, or even throw into fainting and coma. When the overload is severe enough due to kidney injury, patient will go into respiratory distress due to pulmonary edema and also respiratory acidosis. Okay, anemia and infection is not so much. So just remember, in severe acute renal failure, what symptoms or complication they will have? Number one, they will have reduced in volume of their urine. They will turn into reduced urine, oliguria, or even no urine output called anuria. They cannot regulate water. They cannot regulate their electrolyte and acid-base balance. So as a result, they will have fluid overload. Okay, the fluid overload can cause respiratory distress. They will have very bad acid-base balance, so they will develop hyperkalemia. They will develop severe metabolic acidosis. Okay. So this one is wrong. Remove this slide. So this is not important. Okay. So this is the other common causes that you need to know for acute renal failure. Things you need to consider. Differential diagnosis of acute renal failure in the hemodynamically stable patient means it's not pre-renal causes. So common thing is still your post-renal causes like urinary tract infection. So common scenario will be a patient just walk in with renal failure. Patient came in with a urea and creatinine very high, creatinine 800 plus, but their blood pressure is all normal. Means they do not have a clear prerenal causes. They do not have shock. They do not have reducing perfusion. So how do you want to work out on that? So common causes is still the obstructive causes, post-renal causes. So the first line workout will be getting the history of obstructive symptoms like any loin to groin pain that suggests renal stone, any renal colic pain, and hematuria in maturation. Uh, those are the symptoms suggestive of renal stones. Then you want to ask the symptoms of BPH, the suggestive of the obstructive causes. Then renal ultrasound will be important here to rule out obstructive causes. Most of these urinary tract obstruction, they are reversible if you can pick them out earlier and divert the obstruction by putting a stenting, or in BPH patient putting on urinary catheter. Okay, after you rule out obstructive symptoms or obstructive causes, only to consider the common renal causes like drug-induced acute interstitial nephritis or RPGN. No, these are more high-fi and less common causes to consider. Okay. Any question on the causes of AKI?
No, doctor.
So remember the slides, because I think I put up quite a few times, right? Remember pre-renal, renal, and post-renal causes. Just give me 2 causes for each, then I'll be happy. All right. Okay, then we move on to chronic kidney disease. So how do we define chronic kidney disease? So we take a cutoff of the eGFR less than 60 that's present more than 3 months without evidence of kidney damage. Okay, so the cutoff usually take an eGFR of 60. So in Malaysia, actually, we have our own guidelines for management of chronic kidney disease as well, which is a very extensive guide, including how do we follow up and how do we optimize each of the factors, and how to manage when the disease progress into end-stage renal failure. So the kidney failure incidence and prevalence actually is on the rise and increasing, partly because our other metabolic giants like diabetes, hypertension, and dyslipidemia is on the rise as well, and all those are the precursors of the chronic kidney disease. So the causes of the progression of chronic kidney disease, number 1 is still uncontrolled hypertension, number 2 will be uncontrolled diabetes, and number 3 will be uncontrolled diet, no salt restriction, etc. So because of the other comorbidities, DM and hypertension on the rise, CKD number is also increasing, and the number of people on dialysis is increasing on the years as well. And to make it to make the condition worse, CKD is silent disease. So if the patient does not go for regular follow-up or regular checking for urine protein and monitoring a renal function, they won't feel anything. They'll feel normal, like a normal healthy individual. But when the kidney disease progress into into advanced disease, it will be too late to intervene. So usually the risk factor who to screen those who have diabetes or hypertension. In our guidelines, they need to screen at least yearly. So in the clinic kesihatan, they have the NCD workup is actually very extensive. So all this group of patients will arrange to have at least yearly or 6 monthly checking of their urine protein, and also at least one time checking of the renal profile every 6 months. So other risk factor for chronic kidney disease one of course is the aging. Number two, obesity. Obesity, all those metabolic risk factors. Obesity, metabolic syndromes like diabetes, lipidemia, cardiovascular disease, family history of chronic kidney disease, recurrent infection, structural renal disease. Those are the risk factors for CKD. And another thing not to forget is actually drugs, especially uh, elderly that are taking traditional medication or NSAIDs, NSAIDs like diclofenac, over-the-counter painkiller. Those are one of the killer for the kidney as well. They are taking a lot of time for non-specific joint pain, gout, or muscle pain. So over-the-counter uncontrolled taking NSAIDs is more like a blow to the kidney when they already have chronic kidney disease. If you go and take all these nephrotoxic drug, it's actually causing the worsening of the chronic kidney disease at a very fast pace. So our top killer from the Malaysian food. So what are the primary causes of the kidney failure? First one is still diabetes, followed by uncontrolled blood pressure, then followed by other causes like drug use, structural problem, other intrinsic disease like glomerulonephritis, cystic disease. Those are only small proportion of the cause of the chronic kidney disease. So these first two risk factors, they are modifiable. That's why our teaching is to pick up those early kidney disease and intervene, optimize the risk factor to prevent them into progression of end-stage renal failure. Okay, so what are the clinical features of chronic kidney disease you see? So this is quite relevant to you. You're able to see these group features in the ward, especially in C7. Try to pick up these signs in the C7 renal failure patient. If you go to C7 for bedside teaching, it's very likely you're able to see all these signs. Okay. So what do you see in the kidney patient? Usually you notice they're slightly pigmented or yellow. We call it sallow complex. So you look at them, they'll be very sad looking. They look dry. They look slightly pigmented and yellow. Look at lips. They look very sad, very yellow, slightly pale, and have this yellow complexion. We call it sallow face. Okay. Then at the peripheral, you can see the fistula. Look at their hands. Try to feel for the trails at every fistula. Their blood pressure tend to be high, and the neck, because of fluid over presentation, a lot of time the JOP will be raised. They'll be tachypneic, wearing oxygen. Their lung will be wet with crepitation at the base. Those are the common finding in kidney disease patient in the ward. You may also see a catheter in front of the chest wall that is called a cuff catheter. Sometimes you can see the catheter on the neck as well. That's called IJC. So cuff catheter is a permanent catheter where the catheter actually drains into the heart. So this is a portal access for dialysis, right? Usually this is not a first line method for vascular access because of risk of infection. The first line access is still every fistula. Okay. You notice the end-stage disease patient who have thin skin, they will bruise easily. And because of uremia, they will have itchiness, pruritus everywhere. So you see excoriation on their skin. Patient will have peripheral neuropathy as well because of uremia, and they will have most of them have uncontrolled diabetes, so they will have peripheral neuropathy as well. Okay. So how do we screen the kidney disease patient in those with diabetes? So the non-invasive, readily available test will be urine dipstick. So urine dipstick is to pick up any overt nephropathy. If let's say urine dipstick, urine protein is positive 2+, so they are considered overt nephropathy. Then you need to quantify them and perform other scans to rule out other causes. So those are quite overt and late stage already. So our aim is to pick up those early one. So if they're negative, you check for microalbuminemia by doing a more detailed urine protein test we call urine albumin creatinine ratio. This is to screen for microalbuminemia. So if urine protein is positive, so what do? If the test is positive, you need to check their renal function. You need to exclude other causes, and you want to do a renal ultrasound to rule out structural problem if indicated. And of course, at the same time, you want to optimize their glucose control and their optimize their blood pressure. So renal imaging is the first line test to look for the structural problem. Usually what are we interested in renal imaging in chronic disease patient? We want to know about the size. So renal size gives us an idea whether the problem is acute or chronic. So in chronic kidney disease patient, the renal size will be shrunken. Normal kidney size is 9 to 12 centimeter. When the patient has a prolonged kidney disease, usually their size is smaller, most of the time less than 9 centimeter. And they will have loss of cortical differentiation. So the cortical thickness in kidney disease will decrease, and the echogenicity will increase due to chronic kidney disease. And imaging, we're also interested in stones and any evidence of urinary tract obstructions. Okay. So when do we do imaging as a baseline in chronic kidney disease patient, or there's sudden worsening of renal function, or when there are symptoms to suggest urinary tract obstructions? Okay. So how do we manage or treat chronic kidney disease patient? Optimizing the metabolic risk factor. Those are the things that you can do. Those are the only thing you can do. So in diabetic patient, you want to optimize their sugar control. You want to have a very strict blood pressure control, keeping their blood pressure less than 120 over 90. Then you want to start them on ACE inhibitor. Okay, this is one of the very important slides as well. You picture in diagram, but I hope you get this one, remember this one. So how do we manage chronic kidney disease patient? You divide into diabetic or non-diabetic patient. Okay, in diabetic patient, you want to optimize their sugar control. You need to have a very strict BP control. I think the number is less than 120 over 70. Okay, less than 120 over 70. And you want to start them on ACE inhibitor, okay? Either ACE or ARB, because those are proven to improve the proteinuria, okay, to reduce the proteinuria and also reduce the cardiac mortality. Okay, so ACE is one of the very important medication in management of chronic kidney disease patient. So in non-diabetic patient, they have no diabetes to control, so they have to you have to control your blood pressure. You need to have a tight BP control. In proteinuria patient, you want to start them on ACE and ARB. In non-proteinuric patient, you need to really achieve your BP target. Other general measure: first, stop smoking, regular exercise, restrict your sodium intake, restrict your protein intake. Those are the common thing you can do. Okay, this is very important. Again, this is the classification of chronic kidney disease using a GFR. Don't need to remember the number. Just need to remember there are 5 classes of chronic kidney disease. Stage 5 is end-stage renal failure. Okay, so if the patient progress into stage 5, the creatinine progress to increase, the GFR progress to less to 15. So what do we do for them? So basically, when they go into end-stage renal disease, we have a few options here. Some elderly, they would prefer not to do anything. We call comfort care. We're going to palliative management. They may not want to go for renal dialysis. They do not want to do further peritoneal dialysis. They just want to uh, let the nature take its courses, let it worsen. That's what we call comfort care. Other option of renal replacement therapy. Number one is hemodialysis. Number two is peritoneal dialysis. Another resort is kidney transplant. So in overseas, kidney transplant is always the first line management. But in Malaysia, renal transplant is not so commonly done because of lack of donor. So hemodialysis and peritoneal dialysis is still the first line management in Malaysia. So we want to prevent them to progress into the end stage renal failure. So we always refer them early when the GFR is less than 30. So when GFR less than 30 will be around stage 4. So most of the time the clinic will refer when the GFR is around stage 3B. When stage 4 a lot of time is too late. So typically the clinic will refer over when the eGFR is less than 45. Stage 3B, they will start to refer over to further optimize and, or even renal replacement arrangement. Okay. So you need to know two modality of your renal replacement therapy. Hemodialysis, but you need vascular access. Peritoneal dialysis, you need to have someone to do for you, and kidney transplantation. There are two types. One is the living related, living kidney transplant, means donate by family or friends. And you can have a cadaveric transplant waiting for the donors. So in Malaysia is still being done for renal transplant, but just that the waiting list is very long, and if you're lucky, if your family match and willing to donate to you, then you have a living kidney transplant. If no one willing to donate for you, then you have to wait for the cadaveric transplant. The list is very long, and most of the time you will need to have a temporary mode of dialysis while waiting for transplantation. It's being done in Selayang Hospital in Kuala Lumpur at the moment. Okay, so you need to know the difference between hemodialysis and peritoneal dialysis. So what is the difference? So like a picture here. So anyone know what is the difference between hemodialysis and peritoneal dialysis or not? Oh, I still have 15 slides to go. They want? Okay. So I expect you to know more, to explore more during the bedside teaching later, because you'll see this in the ward. Okay, the hemodialysis, the name suggests hemo means blood. Means if dialysis means filtration, so filtration of the blood. Okay, peritoneal dialysis, peritoneal means your peritoneum. Filtration, dialysis means the filtration happen at your peritoneum. Hemodialysis means filtration happen in the blood, right? Which is in the machine now. So in hemodialysis, you need an access. You need to have a stable access where the machine will draw out the blood. The blood will get drawn out into the machine. The machine has a filter in it to filter the toxins and unwanted electrolytes, and then the clean blood will return to the patient. So the problem with it is that you have to do it 3 times a week, every time at least 4 hours. You need to pay, it's expensive, and you have to do it in the center. You loss of freedom. 1 week, 3 times you have to stuck in the center for at least 4 hours. Peritoneal dialysis, use your own peritoneal membrane as a filter. You can done it at home. You just have to exchange the filter water 5 times a day. Give you a better quality of life. Just that you have to able to do the self exchange of a peritoneal fluid. So you have different vascular access, the native fistula, by combining the vein and artery, is still the best mode of access because the less risk of infection. But not everyone able to do a fistula. So elderly will have smaller vessels. The fistula does not get matured in time. They will need a catheter. So the catheter means putting plastic tubes through the skins, through the vessel, through the great vessels, and you position in the heart. So there's two ports in the catheter. One is blue, one is red. So they'll draw out the blood through the machine, to the HD machine, filter to the toxin, and the blood will return back to the heart. The problem with it will be the risk of infection. Okay, so this is how the fistula looks like. Blood going out and then blood coming back in from the machine. So we have complication of the CKD. You have patient will develop anemia due to reduced or red blood cell production because of reduced EPO. They have mineral bone disease. They get fluid overload and electrolyte imbalance. Okay. If they are catheter, they can commonly come back with infection. Elderly may not have the vascular access easily. The principle of peritoneal dialysis is like this. You have a catheter inside a peritoneum cavity. So you put in a dialysate. Usually dialysate will be higher concentration. Is to your peritoneal membrane itself will be the filtration membrane. So all the unwanted electrolytes or water will diffuse through the peritoneal membrane into this into the peritoneal fluids, and the peritoneal fluid will get flow out through the catheter. This is how it looks like. You see the catheter placed in the abdominal cavity, but main complication will be the infection of your peritoneal catheter. You get CAPD, peritonitis. Okay, so the dialysis of choice most of the time will try to advocate patient to do CAPD if they are able to perform it, because it's cheaper and patient has more freedom. It's just that the patient will need to able to do the self-exchange, or they may need to have a helper to help the patient to do it. If it's none, then we'll resort to hemodialysis. Any question on end-stage renal failure before we move on to the last stage?
Sorry, doctor, can you explain back the principle when on the diffusing part?
Okay. So basically, it's like this. In hemodialysis, it's very simple. You filter through the filter. But in peritoneal dialysis, the filter is your naturally occurring peritoneal membrane. Okay. So what we do is in peritoneal dialysis, the dialysate will pump inside the peritoneal cavity. So imagine you have a peritoneal catheter that placed inside the peritoneal membrane in your peritoneal cavity, sitting just next to your gut, next to your organs inside. Then and then every day, 5 times a day, you infuse a dialysate inside. Usually this dialysate is slightly hypertonic one. Usually the sodium will be higher, the sugar content will be higher. So you put inside a peritoneal cavity. So remember your chemistry. So water always flow from a more diluted hypotonic to a hypertonic environment, right? So the dialysis is always hypertonic one. It's just that there are different concentration of it. So when you put a hypertonic solution inside a peritoneal cavity, the water will flow from a hypotonic to the hypertonic region through your osmosis, right? So you move down the diffuse the what's it called, osmotic gradient. All right, that's how the principle works. All right, the water will flow from the hypotonic to a hypertonic dialysate, and then after a few hours you drain this dialysate out. okay, from the same cavity. Just one in, dwell for a few hours, then they remove it, and then they put in the new dialysis again. That's how it works. Okay. Understand not? Can you get that?
Understand, doctor?
Yeah, yeah.
Cannot really.
So yeah, so it did. So you look at it, actually, too many variables in place here. So not everyone suitable for CAPD. Some people will be like their peritoneal membrane, their natural occurring peritoneal membrane. Because we cannot predict, we cannot change how we filter to the osmotic gradient change varies between individual. Some people work, some people don't. And especially when you have recurrent infection, the peritoneal membrane gets scarred, they get fibrous. So the filtration does not happen so good. So in that group of patients, that eventually they may switch out to hemodialysis as well. And the problem with it is the peritoneal dialysis, you need to have frequent exchange. You need to have keep on changing a dialysis, because at one point your diffuse gradient get lost after a few hours. You have to keep on changing a new dialysis. Right? Okay. Okay, so now we move on to the next stage. Will be glomerular disease. Okay, this is something more okay. This is something more complicated. I do not expect you to understand everything of it. Just try to remember the concept of glomerular disease now. So in glomerular disease, basically it divides into glomerulonephritis and also nephrotic syndrome. Okay, so it involves a damage following a number of insults. Can be due to immunological injury, can be due to inherited disorders, can be due to deposition of materials or other direct injury. So whatever injury happened to get glomerular is called glomerular disease. So it can be due to autoimmune, like immunological injury, can be due to deposit other materials. Okay? All right, this chart actually simplified everything that can happen to your glomerular. Okay. Okay, so what can happen to it? So when you have glomerular disease, when your glomerular get damaged, so what is your glomerular actually? Let me go back to the picture. Not this one. So where is your glomerular membrane? Okay. So the glomerular membranes basically we're talking about is this part. Okay. So this is your glomerulus. So all the arterioles will, when the renal artery branches into arterioles, the smaller arterioles will form into like a ball, like a snowball like that. That's called glomerulus. Ultrafiltration happen at the glomerulus. So remember just now, high pressure force the blood through this glomerulus. The filtration happen here, through the membranes, through the endothelial layer of your arterioles. So filtration actually happens here. So it's very important. When your filtered membrane get affected, you develop hematuria, you can develop proteinuria. Okay, so this is the part that you affect. This is what glomerulus is. Okay, so there are multiple conditions that can affect your glomerular. There are primary and secondary causes. So you have minimal change nephropathy, focal segmental glomerular scleritis, membranous nephropathy, amyloid, diabetic nephropathy. You can also have secondary causes like SLE, IgA nephropathy, post-Tract glomerulonephritis. Okay, so there are a range of disease here, and these different diseases can give you different spectrum of manifestation. Can give you proteinuria and hematuria. Okay. So there's only one or two disorder that I need you to understand. The rest is actually too complicated. Can you guys hear? I think it's a bit noisy because of the heavy rain.
Sorry, doctor, it's not really clear.
Uh, is it better now?
Yes, I think so.
Okay. So just remember, the glomerulus can get damaged by different spectrum of disease. Like I mentioned just now, due to this minimal change disease, SLE, IgA nephropathy, and all these diseases can give you different spectrum of manifestation, including different degree of proteinuria and hematuria. Okay. Uh, okay, that's what you need to remember. The most important topic will be nephrotic syndrome. I do not expect to know all these fancy other diseases that's too complicated to you. So one of the most important glomerular disease will be nephrotic syndrome. That is important to you. Okay. So what is nephrotic syndrome? So there are few criteria for you to fulfill nephrotic syndrome. One of it will be overt proteinuria. You need to quantify the proteinuria, which is collection of 24-hour urine protein. The cutoff number is 3.5 gram per 24 hours. When your urine excretion contain more than 3.5 gram over 24 hours, that's called uh, significant proteinuria that fulfill nephrotic syndrome. So, what other criteria inside nephrotic syndrome? Hypoalbuminemia, protein less than 25. When you have losing protein in the urine, automatically your blood albumin will low. So you have hypoalbuminemia. Because you have hypoalbuminemia, you easily get edema, so you have either edema. Patient may have hypertension and you have hyperlipidemia. Nephrotic patient always have hypercoagulability states. Okay, remember these features of nephrotic syndrome. This will be asked in exam. Right? Again, just remember at least three features of nephrotic syndrome: overt proteinuria more than 3.5 gram per day. Number two, hypoalbuminemia, and number three, edema. Or number four, hypertension. Okay. So what disease can give you nephrotic syndrome? Okay. We have primary or secondary disease. Primary means it's disease that's specifically to the kidney itself, like a minimal change nephropathy, FSGS with focal segmental glomerulosclerosis, membranous nephropathy, and mesangial proliferative glomerulonephritis, RPGN. Okay, those are the primary cause of nephrotic syndrome. Okay? Just remember two out of these five: minimal change disease or membranous nephropathy. What are the features in children, adults? Also, you will see facial puffiness due to fluid overload. They will have ascites and pedal edema. Okay. So, causes of nephrotic syndrome, minimal change disease. Uh, like the name suggests, minimal change disease actually just means that when you take a biopsy of this condition, uh, under the microscope, you do not you do not see any specific changes in the light microscope. Only on electron microscope, you look at the podocyte effacement. It's very common in it's one of the very common nephrotic syndrome causes in children. Most of the time, the causes is idiopathic. It commonly happen after a cause of infection. No one can explain this. Usually is self-limiting. And you have focal segmental glomerulonephritis. Uh, Usually this disease has poor prognosis. You progress to diffuse glomerulosclerosis and progress into renal failure. Membranous nephropathy can be primary or secondary. Primary can be due to any autoimmune disease can give you membranous nephropathy like SLE. Secondary will be due to infection, autoimmune disease. Then you need to remember The most important one will be your diabetes. Okay? You can forget others, it's okay. Most important causes of nephrotic syndrome will be diabetes. Okay? Because it can lead into progression, can lead into end-stage renal failure, and because of metabolic changes, it lead to sclerosis and fibrosis of the glomerulus. Okay. These are the secondary causes of nephrotic syndrome. Can be due to metabolic causes, like mentioned just now. Most important, you need to know diabetes. And then other causes will be immunogenic, autoimmune causes like SLE. Just remember one from each category. Diabetes, SLE, cancer related problem will be multiple myeloma, medications, and infections as well. So complication of nephrotic syndrome, because the loss of the proteins, they get edema, the loss of the anticoagulants from the urine, so they'll tend to form blood clots easily. They'll have thromboembolism. How do you work up nephrotic syndrome patient? Let's talk about how they present first. Usually, this nephrotic syndrome patient, either they present, they get detected by urine dipsticks, or they present with swelling. They commonly present with pedal edema, non-specific pitting edema up to the knee, or they present with overload symptoms. And then you check the urine protein, will be sky high. That's how you lead into diagnosis of nephrotic syndrome. So for confirmation of nephrotic syndrome, first thing you do is 24-hour urine protein measurement. Cutoff is 3.5 gram, 3.5 gram per liter per day. And then you want to look at your evidence of hypoalbuminemia. You check for liver function test. Look for the serum albumin, should be less than 25. Then you look for serum creatinine. Cholesterol should be elevated, and eventually you want to rule out secondary causes like diabetes, autoimmune causes, drug, toxins. Then only you think about primary causes. If you think about primary renal causes, like the causes in this list just now, to differentiate this, you need renal biopsy. The management of nephrotic syndrome always treat the underlying causes. Non-specific management will be advising them for high protein diet, salt control, treating an infection. If patient is too edematous or overload, usually give them a course of diuretics to remove the excess fluids. Okay, I think that's all for nephrotic syndrome. Any questions on nephrotic syndrome?
No, for me, doctor.
Usually the renal biopsy is done when?
Okay, so there are a few indication of renal biopsy. So we usually do the biopsy when we do not know what we are dealing with, and the renal function is worsening too fast. Okay, so let's see here, where is the renal biopsy? I think I have one slide talk about renal biopsy. No, not this one. Okay, correct. Okay, so most of the time when we see this group of patients, they comes in with overload, they comes in with nephrotic syndrome patient, they come with overload and pedal edema, etc. And then another group of patients, they come in with hematuria and very bad renal function. So most of the time you try to rule out secondary causes first, like does the patient has very overt diabetic that causing all these problems or not? Does the patient has hepatitis B, hepatitis C, or does the patient takes any toxins, any medication can cause this nephrotic syndrome or nephritic syndrome or not? Then you also want to rule out the autoimmune disease symptoms also. And after you rule out all these, you think that still cannot give you an answer, and the kidney function is still not good, the proteinuria is still persistent, that is the time you do renal biopsy. is basically to confirm or classify which group of patient this is. So we usually do the renal biopsy after we rule out secondary causes and we think of primary disease that's specific to kidney. Then we do the renal biopsy. Or when the patient has a very rapidly progressive glomerulonephritis, means there's young patient coming with a very bad renal function, with a GGFR less than 15 requiring dialysis. Usually this group of patient, after we rule out obvious secondary causes, we will tend to counsel them for biopsy to find out what is the underlying renal problem that gives you a bad renal function.
Okay. Thank you, doctor.
Any other question? Any other question? So basically, this slide summarize this page summarize the renal causes for acute renal injury. So remember, just now we have one slide about this one. We have pre-renal, renal, and post-renal causes. Yeah. So basically, renal causes is all this. Right? Yeah. So basically, this is all the renal causes for glomerulonephritis and renal injury. Okay. Commonly, the one that important for you is still the diabetic nephropathy. Okay. The rest actually are not very important for you to know. Just remember that there are different disease can affect your glomerulus. Okay. Can be autoimmune disease, not autoimmune related, like primary. This group are the primary kidney disease. This group is the autoimmune related. IgA nephropathy, post-tract, SLE. Those are autoimmune related glomerulonephritis. Okay, and those are the primary kidney disease problem that give you the nephropathy problem. Any other questions?
No, doctor.
No question, we call it a day.
Okay, doctor.
Thank you, doctor.
Okay, see you guys tomorrow.
Thank you, doctor.
So you
Thank
guys
you,
have
doctor.
lecture in the morning, right?
Yes.
Yeah. Most likely, I think the venue for teaching tomorrow is still at the same place at level 4. I see whether I can book the room or not at the seminar 1. Okay. So let me know when you guys arrive. Maybe around 10:30 or 11.
Okay, doctor.
Okay. See you guys tomorrow. Bye bye.
Thank you, doctor.
Thank you, doctor.